Blessed, how are you? Or blessed? How are you doing? Hope you guys had a wonderful day. Mine wasn't bad. Alright, let me accept this. I haven't done a co-host. Hi, how are you doing?
Hi.
Stacy here. Who is this little one?
This my brother.
Okay, okay. Alright. How old is he?
So how old you?
No. Green, 5.
5? Okay, okay, okay. Okay. So what are you up to today? I'm Stacy, by the way. What's your name?
I saw you got a poop.
She ain't in the talking mood. But how are you guys though? Let me ask the folks that are here. Oh, let me send out the link or share the page. The lady said no, I'm not in the chatting mood with you right now. All right, so let me send that out. And I would love for you guys to go ahead and like up the page, share the page. All right. And welcome on YT. How are you guys doing? Hi, Eduardo. How are you doing? Thank you for tuning in. Isaac, how are you doing? Thank you, Omar. How's your day going so far? Mine is going well. Mine is going well. You just want to say I'm a bit... Okay, thank you, Life with Lily. Thank you for the nice, the kind words. Omar, hi. Sunworn, welcome. You like my smile? Thank you. I hope you're smiling back at me. Life is like a boy's. I'm from Jamaica. I'm from Jamaica. Good morning. It is 6:50 p.m. for me here in Texas though. Where are you joining in from, Sunwarm? I see 55 persons on YT here. Hi, welcome. Yes, Jamaica, nice, bad. Oh, seeing that you love Jamaica, I would love for you to go ahead and remember to follow my page. You can also check in my bio, the description. There is a link for GoFundMe. Feel free to go ahead and go and donate to my GoFundMe page. And if you don't want to donate to my page, you have the Jamaica, what is it called? supportjamaica.gov.jm, where you can actually go ahead and donate to help victims of Hurricane Melissa. So we have a few parishes that have been affected by Hurricane Melissa, almost over a month now. So they are totally like, out of certain items. And so I would love for you guys to contribute. Even if it's $1, that would be really appreciated. Thank you so much, Tyresia, for subscribing. Fishbowl, hi. I am doing well. Remember to go ahead and tap up the live. Thank you, Whitney, Ariel. How many languages? So I only speak English. All right, I know a little bit of Spanish and French, not fluently though. Thank you, Carlos. Thank you. Somiaman, welcome. You understand Patois flying with kings? Exactly. Yeah, I know 4 or 5. Okay, that's nice. That's nice. How do you live in the US? Oh, I migrated. I came through one of those nursing recruitment companies. So one of those agencies I signed up with from Jamaica as a nurse, and they sponsored me here. So feel free, if you have any questions regarding that, you can also ask it. I will try to my best to answer it as as we go along. So what's that? Dildora. I'm 11. Okay, welcome, welcome. Tyresia, you're from Texas. Where are you now? Where are you currently? Bure, hi, how are you? Oh, you're Ali? Okay, nice. Hi, Ali. Welcome, welcome. Alright, guys, let's try to tap up the live. Char colors, how are you? If we are talking about development across the lifespan tonight, I'm leaving, but if not, hi. 3 dots in a car. Welcome. Trip metal detector. School starts January. Hoping to become an ER or ICU nurse. Way to go. Yes. Well, anywhere you're working as a nurse is gonna be good, but because I'm an ER nurse, then I'm rooting for you. I'm rooting for you. But any specialty should be fine. I love dancehall. Okay, do you play soccer? No, I don't play soccer. Thank you. Yeah. David's, welcome, welcome. So tonight, tripped metal detector. Thank you for the heart me. Oh yes, guys, remember to go ahead and claim your daily heart me's. You can click on the little heart here if you're not so sure. Click on the heart here and then just go about with collecting your points and tap up the live, share the live. Those are the only 2 things I'm asking for. I'm already at a vet tech, EMT, and DOSA. So I'm used to frontline. Okay, I see why. I think probably you're gonna be bored in ICU though. Tripped metal detector. I think you're gonna be bored in ICU. Messi or Ronaldo? Messi. The real Zago. Hi, how are you doing? How old are you? 20 years? Yes, I'm 20. Yes, the real Zago. Go ahead and ask your question. I applied for nursing job, got declined. Apparently, you need at least a high school diploma. Yes, Flying Kings. Yeah, you need to get your high school diploma. Then you get your bachelor's. Then, you get your license and apply. Moi, welcome. Mukhtar, 160, welcome, welcome, welcome. I like, thumbs up. Oh, okay. Thank you so much, Mukhtar. Thank you for doing that. So you never did know Flying Kings? You just wanted to apply and go and get a nursing job? No, and I said work. Oh, you're in Pakistan. Okay, nice. 6. All right, let me see it. 7, 6. 6, 7. I don't know what's up with that number, but I hear everybody saying it. I figure you are Flying Kings. I figure you are. Thank you for the puff. 3 dots in a car. So what area are you in, Flying Kings? Are you a nursing student? Are you currently a nurse or what? I don't know the hand gestures, Collins. I don't know the hand gestures for it. I just hear some kids saying the number, and that's it. And I was like, why not 1, 3? Why not 1, 2? Why not 8, 9, 10, 11? Why 6 and 7? But yeah, it seems as though everybody is saying it. I don't know. So I say one fool makes many. I'm upset. You just see my message. NX World, welcome. Thank you for commenting there. I don't know what message you're talking about though. Yeah, it can be any number. 1, 2, 3, 4. It doesn't have to be, that specific one. I'm actually a retired engineer. Okay, nice. Siggy, welcome. I'm good. I'm not gonna lie, I'm a little bit tired. I was on the road today, not doing any work related, but I was like just up and down doing a lot of things. I think Oxford Dictionary name 6'7" is the word of the exactly. I tell you, I was walking and I had a friend. They were wearing 6 and one was wearing 7, a couple. And everybody was like 6, 7. And I'm like, what is up with the 6, 7? Because when I saw them, it meant nothing to me. And I seen grown adults saying the same thing, asking them to take pictures. And I'm like, are we kidding? What's up with the 6 and the 7? And she's like, look, it seemed like it's a trend. Her son came home with it and she decided to just wear it. And everybody wanted to take pictures of both of them together with the number. And I'm like, what? She's like, yeah, it's a big thing. And then I keep on coming online and people will be saying, the numbers. And I'm like, okay, then it's a thing. Hi. How are you doing? No, I'm a nurse. I am a nurse, not a doctor. People are just nuts these days with these silly trends. Exactly, Shocks. Exactly. Plasma, welcome to the page. I don't need to say that I'm not a cat, okay? But wagwan. Big up yourself. All right. So, all right. What time is it? 7 o'clock? All right. So I'm going to give 5 more minutes to the folks that are Jamaicans that are running behind the clock. We're always late. So I am early today. I'm going to give them 5 more minutes. A nurse who is more than a doctor. Siggy. Thank you, Banaz. Yeah, I need good energy all the time. All the time. Yes, I had dinner earlier. So, what they call Sunday, Monday. But today I was Tuesday. Yeah, man. So Sunday, Monday, Tuesday. That's what I had with a little piece of Irish, sweet potato. It was a ton of mix up. Sweet potato and the macaroni, pasta, and what else? Cabbage. Yeah, everything. Yeah. It was a lot. Matt Mantar says, my face look like I know you before. Huh? Are you from Jamaica? You went to Manchester High? Are you from, did you go to Northern Caribbean University? Anywhere along that line, that's where I'm from. But I don't know your name though, so yeah, you don't look familiar. No. Oh, you're from Turkey? No, boss. We don't know each other. You've never seen me apart from on this page here. But remember, go ahead and subscribe to the YouTube page at ThinkNursing. Follow me on TikTok as well at ThinkNursing. And we do live streaming for nursing content or study session at 7 p.m. Central Standard Time on Tuesdays and Thursdays. I'll do pop in throughout the week. Not really guaranteed on the other days, but on Tuesdays, Thursdays, definitely I'll be here. Bob Marley is your true legend. Love his music for many years. Yeah. Damian Marley as well. Yeah, I love Damian Marley. Well, I love the songs, I love their songs. Victoria Strang, welcome. Who is joining us for the first time? Just say me, or just put a heart in the comment box if you're joining in for the first time. And thank you for taking the live up to 1K. That's nice. UT22378. Okay, welcome, welcome. These kids are cool too. Okay, okay. Victoria, welcome. I hope you follow the page, subscribe to the YouTube page, because the full length of the live streams are posted over there. So just in case you enjoy tonight's sessions and you want to see what we did weeks ago in terms of the questions, they're all posted on YouTube at ThinkNursing, the same name here. Yeah, so go ahead and do that when you get a chance. So first, you speak Spanish? No, dear, me no speak Spanish, Omar. First time talking to you. Love talking to you. Health Plus Limited, thank you so much. No, I'm not from Nigeria. I'm from Jamaica. Okay, so 2012, Jack Players is watching for the first time. Okay, nice. And thank you, 3 dots in a car, for liking up the live. Oh, you're in Grenada, Health Plus. Okay, nice. I know some persons from Grenada. Nice to meet you, Mantar. Goat and rice and goat. Why you don't respond to me? What am I missing, Mustaf? If you know some answer, you probably just jump over your comment. You're probably saying something that I don't have an answer to. All right, so it's 7:05. Not gonna have my folks here waiting too long. So let me just turn this thing around. So I'm gonna flip the camera. Hold on. I'm gonna flip it back around here and get this thing. Sometimes I can't see the cursor. Okay. So let's go. So we're gonna do, I think I have like some case study type questions that we were doing from last night. We'll do a few multiple choice. What is it? No, not really multiple choice. I'll ask the question, you tell the answer. And we have some OB cases, obstetric cases, pediatric cases that we'll just run through. For the first set, so it's a mixture of a little bit of a fast pace, and we'll do the case studies in between. So we'll start. Oops, it's me, it's her. Welcome. We'll start with those. You're so handsome. Thank you, beautiful. My boss was in Jamaica 5 days ago. Okay, nice. When did I transition from Jamaica? In 2016. Yeah, in 2016, September. All right, let me turn the camera around so you guys can see the questions. I know probably a lot of you are going to jump off. You're probably not here for nursing questions. Okay, but yeah. Let's zoom it in. Zoom. Okay. Remember to go ahead and share the live. Can we get a share on the live, please, on TikTok? Can you just share it to your, if not to your page, like, you know, your, what you call it, your story, or just share it with a few persons. I have only 2 shares on the live. That would be nice. I see 13 persons here. So when we share the page, when we like the live, it gets it out to more persons. Just think of a virus. Yeah, that's not a really bad virus. So you get everybody infected. So it's the same thing. I wanted to, you know, get into other persons live and or on their page, so we can have more persons coming over. Yeah, I don't want more crowd over here. Yosef Amada. All right. I guess nobody wants to share the live. But thank you so much, though. 3 dots and a red card. Let's go. Oh, let me move this back over here. So that's where we ended last night. So, yeah. So these are some the questions is gonna be on the board, and you just give the answer, what you think, and we'll quickly rush through these, and then we'll get to the case study. We'll do some more just to kind of get the vibe going. So a patient on warfarin has an INR of 5.2. What is the antidote? Danisu, welcome, welcome, welcome. Dame, welcome. So vitamin K, 3 dots on a car. Yes, it reverses warfarin anticoagulant's effect to reduce bleeding. So hopefully by the time we start, a lot of persons will jump on. Before giving digoxin, which electrolyte must you check? So you have a patient that is on digoxin. Which electrolyte must you check? So we know that you check the heart rate, but what electrolyte? Lab value should you check? K, potassium, yes, 3 dots and a red car. Ziggy says potassium, yes. Why do we check potassium? Why is potassium important for that patient to be checked? What's the relationship between potassium and digoxin? Because it influences heart rhythm. Okay. So when the potassium is low, digoxin binds to it, and then that can trigger, the toxicity, increases the levels, and then cause toxicity. So it's very important for you to check your potassium level, because low potassium increases the risk of digoxin toxicity. That is not detailed enough, I know. You're good. As long as you understand what you're saying, then, we're okay. A patient on furosemide reports weakness and cramps. What imbalance do you expect? A patient on furosemide reports weakness and cramps. What imbalance do you expect? No, sodium. Okay, yes, so potassium loss. So Ziggy, they're losing potassium, hence they're having the weakness and the cramps. So hypokalemia, yes. So remember, it's they're wasting. So they're losing potassium, resulting in the cramps and the weakness, which is giving them the hypokalemia. I was psyched out by saying potassium 3 questions in there. You're good. So loop diuretics, that's a class of drug for furosemide, causes potassium loss. So when you have your patients on furosemide, just make sure you're keeping an eye on their electrolytes, the cardiac rhythm, because of the arrhythmia risk. What medication reverses opioid overdose? Which medication reverses opioid overdose? You have a patient that is on morphine, naloxone. Miss Attitude 126, where you from? Welcome. Narcan is the street name. Yes, stripped metal detector. So Narcan naloxone is the antidote for your opiates, because it quickly blocks opiate or opioid receptors and restores breathing. Before giving metoprolol, which vital signs must be checked? So before giving metoprolol, we know that is a beta blocker. Which vital sign must be checked? Blood pressure. Daniel says no. Pulse, okay, nice. So heart rate. Yes, Miss Attitude. Danny Hughes, why you said no? What were you referring to? Or probably you were trying to type BP. I don't know. Omar Davis's quiz. Yes. Martha, welcome. Julia, welcome. So you want to go ahead and check the heart rate because it's a beta blocker, lowers the heart rate. So hold it if the heart rate is too low. So what range are you looking for in terms of the heart rate or the rate for the heart rate to be at in order to give this metoprolol? It has to be above 60 to 100. Nice. Above 60. Because if you have them at 110, you can still give it. Because it's going to drop. It's going to lower the heart rate. Good. Which lab monitors heparin? I think probably only 3 dots in our red cars to that one. Which lab monitors heparin therapy? APTT, yes, nice. And we know that the INR is the one for warfarin. So it measures clotting time and guides your dosing. Okay. What is the antidote for your benzodiazepine overdose? What is the antidote for your benzodiazepine overdose? Benzos. You have a patient, one F word. Oh God, I don't know. Flu. Influenza A or B, Z. Flumazenil. Yes. Mommy J3, thank you for helping us out here. Yes, that's it. As long as you know to probably even write it, that would be good. Fluma something. As long as we don't say flu A, but as long as you can write it out and you can identify the name itself, we're good to go. Okay. Flumazenil reverses benzodiazepine effects by blocking the receptors. So here's the spelling. That's for your benzo overdose. Give me some names of some benzo. Give me a few benzos that we know. Or some of the common benzos. I thought I'm the only one who have problem with the names. No, Siggy, you might be surprised every time I ask here, type in what TPA is, or you know, just some little what do you call it now? Not acronym. But yeah, when I ask them to go ahead and just say, okay, then tell me what these are, sometimes persons don't remember it. Lorazepam, diazepam, all different PAMs. Good. Alprazolam, yeah. Once it's a PAM, you're good. Ranji, welcome, welcome. Don't know what you're saying in that language, but I think you're saying hi. What imbalance is this? ABG with a pH of 7.25, CO2 of 60. What ABG imbalance is this? So pH of 7.25, CO2 of 60. Okay, so I see metabolic acidosis. Okay, is that correct? We'll get the acidosis, but what system is this? CO2 has to do with what system? Respiratory. Yes, Bree. Angel, correct on that one. So, remember, CO2, think of the lungs, okay? And then if you have your bicarb, the HCO3, think of your kidneys. So you got it correct in terms of the acidosis, but the CO2 is for the lungs, and then if it's the bicarb, then it is your kidney. So wait, CO2 level respiratory acidosis. Yes, stripped metal detector. So if this patient was supposed to be compensating in any form, what will be this patient compensating? What system will be compensating for this imbalance? So you have this patient with a respiratory acidosis. What system would be compensating? The musculoskeletal, the neuro, cardiovascular. Which system is going to be compensating? So the patient is in respiratory acidosis. Which system is going to be compensating? Yes, 3 dots on the correct card. You know, sometimes you have to confuse everybody so we can see. You don't want to say the obvious. We know that ABG has to do with what? How many systems? So let me see where the headspace is. So what system? You have a patient that is in respiratory acidosis on the board. If that patient is supposed to be compensating, which system will be compensating? Thank you. So Danny Sue says kidney, and Angela says, Angel Tasha says kidney, the metabolic. Yes. So remember, the pH tells the acidosis here. The CO2 has to do with the respiratory, and if the respiratory system is affected, then the metabolic, which is the kidney, the bicarb, is the one that is going to be compensated. If this was your bicarb, HCO3, if that was there, we know that this would be metabolic acidosis, and the system that is going to be blowing off that would have been the respiratory system. So the respiratory system is going to be compensating. Okay, so it's always one of the two. So if they're in respiratory, you have the kidneys that take over with compensation, and vice versa. Mariel, welcome. Thank you guys for tuning in. Remember to go ahead and tap up the live and follow if you haven't done so as yet. So this one, respiratory acidosis, high CO2 from hypoventilation decreases pH. What imbalance is this? pH of 7.5 and a bicarb of 30. What imbalance are we seeing here? Janice Sue says metabolic alkalosis. Gina says metabolic acidosis. Alpha, welcome. Okay, so metabolic acidosis. You're not saying anything with 3 dots on a red car? What's the normal pH? What's the normal range for pH? .35 to 7.45. Okay, so this is on the higher side, 7.5, which means that this patient is, so if the higher end is 7.45 and this is 7.5, so this is what? Alkalosis, nice. And then we said that the CO3, the bicarb here is 30. What's a normal bicarb? (22 to 26). Nice. So this patient is in what? Metabolic alkalosis, bicarbonate. Yes. So elevated bicarbonate raises the pH for this patient, okay? So this is 7.4. So always just try to look at the numbers, and then from there it helps you. We know that this is the kidneys that is working. If this patient is supposed to be compensating, if the kidney is, if this patient is metabolic alkalosis, the kidney is being affected, the system that is going to be compensating is going to be your respiratory system. We'll go to another one similar. I'm going to put this with it. Okay. What imbalance is this? Oh, hold on. Yeah, what imbalance is this? So metabolic acidosis. Is this patient compensating? Welcome, Emma Oda. No, because the number is within the range. Okay, so sometimes you'll see them have even though the patient is not compensating, they'll have it there. It's like, they'll have it as uncompensated, or yeah, they'll have it as uncompensated, or they'll probably just have the regular, like, metabolic acidosis, and that's it. What if I had 47? What if it was 47? The CO2 was 47. What would be this imbalance we have here? Respiratory acidosis, okay. Metabolic. So the CO2, is the CO2 normal? The CO2 is not normal, so I want it to be anywhere between like 35 to 45. So the CO2 is high. So, okay, so we know that both systems are involved, right? So we know that both systems are involved. So we have your So when you have your pH that is low, your bicarb is low, and your CO2 is high, it's a mix. It's a big, So it's a So it's a partially compensated because the CO2 is not, it's not within the normal. Yeah, the CO2 is not in the normal. So even if the CO2 was, 46, and even though in the real world we'll be like, okay, 45, 46, you'll probably say, oh, no, it's still partial. Once it's outside of the normal, it's going to be partial. Okay? What is, hold on 1 minute, sorry, let me finish this. All right, so we'll say this is the, as we say, metabolic acidosis with partial compensation. All right, so it's metabolic acidosis with partial, yes, partial. So it is metabolic acidosis because both of these are going in the same direction with partial compensation, respiratory compensation. Okay. So that was the original question. So metabolic acidosis, it is low bicarbonate, lowers pH. So seen in DKA patient renal failure. How come it's not respiratory? So the respiratory system is high, so CO2 is high. What was it again? 47 we had. How do you keep resistance sometimes? Respiratory and PCO2 are opposites. Metabolic and pH are even. Metabolic. Respiratory. CO2 is high, it's 47, high CO2. Response opposite and metabolic equals. Okay, Rose says use mnemonic Rome, respiratory opposite and metabolic equals. Respiratory opposite, metabolic equal. Respiratory opposite and metabolic people. I'm trying to. It's a mix here. I guess we all need to review the ABGs. because as I say, we already gave the answer earlier. G3. I don't know how to explain it again. So we said this is a metabolic acidosis with a partial respiratory compensation. It's mixed. Yeah, the answer, we had only added this so we can actually see what is compensating. So this was the original, this is what we were looking at first. So this is not compensating. Compensation would be a low CO2. So you're saying even though the 47, the CO2 of 47, the patient is not compensating, you're saying? Chad? Okay. All right, let's go on. Let's continue. Because you guys are 35 will be compensation. Okay. So, which ABG imbalance is common in anxiety and hyperventilation? pH is low, so there's a compensation, but if the pH is normal, then it will be a full comp. Then it will be a full compensation. Yes, Y gold, respiratory alkalosis. So because the patient is blowing off the CO2, making the pH rise. What ABG imbalance do you expect in DKA, diabetes ketoacidosis? What imbalance do we know of for your DKA? Metabolic acidosis, the ketones increases the acid in the bloodstream, resulting in that. And iron gap metabolic acidosis, okay. Hopefully, I think we have only 2 more questions for these quick ones. What is the main issue in left-sided heart failure? What is the main issue in left-sided heart failure? Lung issues, nice, yes. Fluid backing up in the lungs, so the left ventricle can't pump, and so you have that pulmonary congestion. So anything respiratory you'll tend to have with your left-sided heart failure. What is the hallmark sign of right-sided heart failure? What is the hallmark sign of right-sided heart failure? Edema, peripheral edema, jugular vein distension, rest of the body. Nice. So fluid backs up into the systemic circulation, and so you have the peripheral edema, you have swelling in the abdomen, hepatomegaly, splenomegaly, all of those megalies. What happens to organs during shock? So we have a patient in shock. What is happening with their organs? It's shutting down, okay. It's talking about end organ damage. Ziggy, they're not getting enough oxygen because a poor perfusion leads to organ dysfunction. Increased perfusion to the organs, less the extremities. Okay, yes, it's JAG. So poor perfusion taking place leading to, you know, organ dysfunction. What happens to CO2 during hypoventilation? What happens to CO2 during hypoventilation? Increases, you retain it. So just like in your COPD, CO2 increases, resulting in respiratory acidosis. So reduced breathing leads to CO2 retention there. In sepsis, what happens to the blood vessels? What happens to blood vessels in sepsis? You have massive dilation, vasodilation taking place. No, actually the opposite of constriction. Yes, you have massive vasodilation, so you have your hypotension that is taking place. So they vasodilate, causing low blood pressure and decreased perfusion. So hence why the priority for these patients is gonna be what? What is the priority for your sepsis patient? It's a form of distributive shock. Yes. So based on the pathophysiology and what you guys are saying, what is the priority for a patient that comes in with sepsis? We see oxygen. Yeah, we need oxygen, but the priority based on the, you know, the condition itself. The pathophysiology, this patient needs what? The patient needs the fluid. Yes, Candice. They need fluids. So start with the fluids first. It's Jazz, and then if they're not responding to fluids, then you can think about your vasopressor. But if you're in the exam, they want to know, okay, then you know what is happening with sepsis, and the most important thing is to get that fluid on board for perfusion. First grade nursing. Yes, Scarlet Fire. Why does DKA patient breathe fast and deep? You talk about the cosmal respiration. Why does that happen? So we just talk about DKA patients. They're in metabolic acidosis. Why are they breathing so fast and deep? To get rid of the acidosis. Hi, TS Music. How are you doing? Yes, so because of the ketone, they're trying to remove all of that. So they tend to breathe very fast and deep. So they're blowing off the CO2 and reducing their acidities, the compensation for metabolic acidosis. So we know that this patient is in metabolic acidosis. So if this patient is in acidosis and they're blowing off CO2, which system is compensating? Because they have CO2 to reduce the acidosis, yes. So which system is compensating for this patient? Ziggy? Are you messing around with me now? So, okay, yes, the respiratory system. You get that, Ziggy? I see you put, okay, yes. So the patient, metabolic, the kidneys giving problem. The patient here, the metabolic system is being affected. So they are having their respiratory system compensating. Not your day. No, it's your day. Now is the time to make the arrow so we can, you know, learn and move on so we can pass the exam. Yeah. What does an S3 heart sound usually indicate? So what does an S3 heart sound usually indicate? Murmurs, okay. Valve construction. Heart failure, fluid, excess fluid, yes. Pulmonary edema, things like that. So fluid overload or early heart failure, rapid filling of the volume, overloaded ventricle. I would say that with the S3 heart zone, young adults, children, can be normal for them. Okay, athletes, it can be normal for them to have a S3 and not having heart failure. So just remember that. But a lot of times when you have your S3 in your elderly folks, just think about heart failure, you know, volume overload, specifically dilated ventricles. Yes. Why does pneumothorax cause low oxygen level? Why does your patient with pneumothorax have low oxygen level? Why does pneumothorax cause low oxygen level? The lung is unable to expand properly. Okay, ear trapped. Guttle, what's that? Gutlet. So collapse of the alveoli, decreased ventilation. So inadequate gaseous exchange taking place because of that. So the lungs collapse, so they can't exchange, you know, air. Air in the pleural space prevents lung expansion. Taisha, yes. Okay. All right, let's try to get the live tap up a little bit and share. And if you haven't followed us yet, I would love for you to go ahead and follow the page here. If you're joining us late, you can get the full length of the live streams posted on YouTube. I'm streaming on YouTube as well. So go ahead and subscribe to the page over there to watch the full length of the live streams if you missed them. Okie dokie. Thank you for the follow, Ari. Rose, thank you for the heart. And how is the live stream going so far? Are you enjoying the streams or what? Thank you guys for liking up the live. And on YT, I would love for you to go ahead and give the video a like. And remember to subscribe as well. I love how you ask follow-up questions. Okay, no problem. 3 dots and a red card. Danny Stu, I see you. Oh, Candace, your finals tomorrow. Okay. I know you'll do well. What area you'll be tested on tomorrow? I've worked more oxygen and ventilation questions. Yeah, that's fine, but you know, try not to spend too much time on that. Just understand the basics, because you're not gonna have a lot of those questions on the exam. But try to understand the basic, you know, the basic imbalances. Just passed my final today. You got this, Bambi. Okay, so Bambi Pretty says she just passed her finals today. She's telling everybody, you guys got it. All right. Mother baby. Okay. Foundation is in assessment finals. My foundation's in assessment finals is Thursday. Okay. We're going to speak it into being. All right. You guys are going to do well. I think I have some OB question tonight as well. Carousel, welcome. Okay, so let's go on to one of these case study. What time is it? 7:46. So we have a 47-year-old female, type 2 diabetes, ulcerative colitis. She says that I feel extremely weak and can't breathe well. Patient is arriving from home with 3 days of diarrhea, chills, and poor oral intake. So type 2 diabetic, ulcerative colitis, feeling extremely weak, can't breathe well, 3 days of diarrhea, chills, and poor oral intake. The temperature is 103.1, tachycardic at 128. Blood pressure is 84/48 and respiratory rate of 34 breaths per minute. And it's shallow. So we know that this patient is, you know, not doing so well. So hypotensive. Okay, so this patient in sepsis. SpO2 86% on 4 liters nasal cannula. Skin is mottled. Cool capillary refill greater than 4 seconds. And the urine output is 15 mils per hour. So patient is a little bit dry. The lung sounds bilateral crackles. Decreased bases in the decreased bases. Mental status confused and disoriented, and extremities cool and weak pulse. So the initial labs, white blood cell count of 22,900, lactate of 5.9, creatinine 2.1, BUN 34, glucose 312, ABG on 4 liters. We have a pH of 7.28, PaCO2 of 30, bicarb 14, and PaO2 of 59. Nothing is good here. Ziggy is saying, yeah, everything abnormal. So we know that this patient is in metabolic acidosis with a respiratory compensation, severe hypoxemia. So we say patient is acidotic here. We have CO2 of 30, the bicarb of 14. Okay, so we say metabolic acidosis and 30 CO2. Patient is compensating. The patient is severely hypoxic. So the chest x-ray does show diffuse bilateral infiltrate, suspicion of early ARDS. So infection, lactate is high, yes. So the orders you receive for this patient that is in sepsis is going to be 30 mils of fluid, crystalloid bolus, IV, Zosyn, blood cultures ×2, high flow oxygen up to 6 liters per minute, sliding scale insulin, vasopressors if the MAP is less than 65 after fluids, okay? So you're not going to jump to this one because it's ordered. It says if the MAP is less than 65 after fluids. And then you repeat your lactate in 2 hours. So based on everything that we hear with all of those lab values being high, abnormal, we're going to go ahead and select all that apply. So, which findings indicate sepsis, septic shock with possible ARDS, acute respiratory distress syndrome, progression? Select all that apply. A, lactate of 5.9. B, PaO2 of 59 on 4 liters of oxygen. C, blood pressure of 84/48. D, white blood cell count of 12,000. E, crackles with diffuse infiltrates and capillary refill of less than 2 seconds. Select all and apply. So which finding indicates septic shock with possible ARDS, progression? A, B, C, D, A, B, C, E, A, B, C, F. Okay. All right, so let's go through. I see a few persons with A, B, C, E. So let's treat each answer as a true or false. Lactate of 5.9, we're definitely going to keep that one, okay? Because this is too high. This is too high. So we're going to keep A. PaO2 of 59 on 4 liters is very low for the oxygen, so we're going to keep that one as well. Blood pressure, 84/48, too low. Patient is hypotensive. All of those are, you know, because of shock here, ARDS. So we're going to keep them. In terms of the pathophysiology and what we know in terms of the effects on the body, the major organs with septic shock, we're going to say lactate, your oxygen, blood pressure, all right, are going to be a part of that. White blood cell count, 12,000. Is that something we're going to be keeping? I can put a question mark beside this. Yes, we understand that the patient is septic or has the fever, but is that indicating possible ARDS progression? So that's why I'm saying I'll put a question mark beside it. Crackles with diffuse infiltrates. Is that something that is indicating? Could put a tick beside it, okay? Then you have a capillary refill of less than 2 seconds. Is this normal? Is the capillary refill normal or not? So we want capillary refill to be less than 3 seconds. So that is normal. So I want to be keeping this. So we're going to say oh, sorry. There's another one here. Creatinine 2.1. So we have creatinine 2.1. We're going to keep this one in as well. All right, because the kidney, it's elevated. So we're going to keep it. Okay, nice. So everybody that says A, B, C, E, G is correct. So A, B, C, E, G. So we said that the white blood cell count would have been a question mark and the capillary refill would have been normal. So high lactate, hypotension, worsening oxygenation, kidney injury, and the chest x-ray changes all indicate multi-organ dysfunction and ARDS risk. So let's go back up to the question. It says, which findings indicate septic shock and possible ARDS progression? So we're looking at all the major organs. Yeah, nobody had seen the G, so we said we were going to keep it. Because everybody was saying yes after carousel. So indicative of shock, septic shock. We're thinking about, your organ, your major organs are involved. And you notice that you have your CO2, you have your lactate that is high, your blood pressure is low. And we said that your creatinine, you have kidney injury going on. So we're going to keep all of those. And then the x-ray, as I said before, okay? So high lactate, hypotension, worsening oxygenation, kidney injury, and the chest x-ray are all indicative of multi-organ dysfunction and ARDS risk. Nice. Somalia, welcome. Thank you for the gift. Yes, I'm from Jamaica. Charnet. What is a priority nursing action right now? So what is a priority? And what we understand by priority? Priority is the one thing that you need to do to save the patient life, the one that is life-threatening for the patient. So it says pick one. Even though you have 5 options, pick one. What is the first? What is most important for the patient? We understand that the patient up there is, we understand that this is the patient. Lab work, we said the patient is metabolic acidosis, hypotensive. The patient is in septic shock, okay? And we said the patient is, urine output is 15 mils per hour, cool, mottled, and the whole 9 yards. Tachycardic at 128, febrile at 103, respiratory rate of 34. So based on the scenario, what is your priority for this patient? Worsening oxygenation, oxygen be first. Okay. So let's go down to the question here. So you pick one. We're only picking one. What is a priority nursing action right now? A, increase oxygen from 4 liters nasal cannula to 6. B, start vasopressors immediately. C, begin high flow nasal cannula as order. D, administer sliding scale insulin. Or E, insert a Foley catheter for urine. So I see B, C. So 1A channel says, so start high flow nasal cannula oxygen as order. Maybe C. And then we have, so C. And then we have B, start vasopressors immediately. Michael says vasopressors immediately. Okay. So increase oxygen, begin high flow oxygen. I feel like he needs a non-rebreather though. Michael, okay. So, and then, so yeah, so 4 liters via nasal cannula and then from there. So we're gonna say C because this oxygen is severely compromised. High flow delivers your high FiO2, PEEP effects, and improve alveolar recruitment in early ARDS. So vasopressors and Foley are important, but oxygenation is life critical first. Vasopressor. So if you're looking at the airway, breathing, and circulation rule that we're supposed to be guided by, Faren, vasopressors will be where? Vasopressors will be on the circulation, right? So if you can't find your airway, if you have an airway problem, you address it. If you have a breathing problem, you address it. Oh, sorry. Okay. Thank you, Faren. Sorry about that. And then you go on to circulation, okay? So increase O2, 4 liters via nasal cannula, or begin high flow nasal cannula oxygen as order. Then you'll go with that one. Foley is gonna be like later on. Administering sliding is after. Vasopressor, you're gonna start your vasopressor after you've done your fluids. So if the patient has gotten the full fluids and they're not responding, then definitely start your vasopressor. Okay. So we're gonna place these in the correct order. So begin broad spectrum antibiotics, apply high flow oxygen via nasal cannula, obtain blood cultures and start 30 ml per kg fluid bolus and reassess the MAP and the urine output. So you have the patient and you're gonna be doing all of the orders for the patient. What order will you be going in? So 2, definitely. I see everybody saying 2. So we're gonna give the patient some high flow oxygen. Then I see we're gonna be giving the fluids. Who said fluids? Okay. So yeah, so 2, then 4, I would say. So start with your oxygen, then you're gonna go to volume, you're gonna go to C. So you start your fluid. Then which one? You would go ahead and get your blood cultures. Then you get, so that's 3. So 2, 4, 3. Then you do your broad spectrum antibiotics and then you reassess. So we're gonna say 2, 4, 3. 2, 4, 3, 1, 5. Okay, cultures before antibiotics all the time. So begin broad spectrum 1. No, not 1. So it's gonna be 1. Then you're gonna go 2. Then you're gonna do 3. Then we're gonna go 4. Then we're gonna go 5. So that's the order. Apply the oxygen, then you give your fluid. Then you obtain your blood cultures, then you begin your broad spectrum antibiotics and then reassess after. Okay. So oxygen first, fluid before vasopressors, cultures before antibiotics, and reassess for perfusion. How will you know that this patient is responding to the fluids? How do you know that this patient is perfusing well? What are you going to be monitoring? Thank you, Tony, for following. Okay, blood pressure. MAP above 65. Anything else? All right, we're done with the blood pressure. We're done with the blood pressure. Anything else apart from the blood pressure? That's right, Ziggy. That's what I'm looking for. Your urine as well, okay? So that's how you know your patient is perfusing well. They start putting out, urine. So the kidneys are working. Okay. But all of what you're saying, yes. But in terms of when you're reassessing and you know that your fluids, your body, because remember it's sepsis we're talking about. So if your body is in shock, how are you going to tell that, yes, the amount of fluids we're giving? Because sometimes you can be giving 4 liters, 5 liters of fluid, and you ain't getting any urine out. Okay, so if you notice that your patient is producing urine, then that's a good, a good look for your patient. Because sometimes they still have, decent blood pressure, but they're still not putting out any urine. So make sure you're keeping an eye on your urine output and make sure it's like, at the 30 mils that you're looking for. Okay, so after fluid bolus and high flow nasal cannula oxygen, your new ABG is pH of 7.21, PaCO2 of 55, bicarbonate of 17, and a PaO2 of 63. What imbalance is this? So you've given the fluids, the patient has gotten some, some oxygen, and this is the new reading that the respiratory therapist brought to you. What imbalance is this? So pH 7.35 to 7.45. So they said this is acidic, 7.2. You have the PaCO2 of 55. Want it to be what, 35 to 45. This is 55. You have your bicarb, that is 17. Okay. PaO2 of 63. Partial compensation, yes. So this is what, respiratory acidosis with partial compensation. So which interpretations are correct? So select all that apply. Okay. So which compensation is correct? A, metabolic acidosis only. B, combined metabolic and respiratory acidosis. C, worsening CO2 retention. D, improving oxygenation. Or E, impending respiratory failure. So which interpretation are we seeing here based on the lab values there? Is it A, metabolic acidosis only, B, combined metabolic and respiratory acidosis, C, worsening CO2 retention, D, improving oxygenation, or E, impending respiratory failure? It's a select all and apply, remember, all right? But if you feel as though that's the only one you take your 1 point and go. But always try to look for 2, at least 2 in your select all and apply. So we have, so anytime you see any answer that has only, you just put that as a wrong, okay? Don't even bother look on that one. So we have your combined metabolic and respiratory. So we have B. We also have your, is it worsening CO2 retention, improving oxygenation, or impending respiratory failure? Oh, so we have B, C, E, B, then D. So combined metabolic respiratory acidosis and improving oxygenation for B and D. Then we have C, worsening CO2 retention and impending respiratory failure. Okay. Why B? Okay, so Farron is asking B, why B? Let's go down. So we have B, C, E. So Virgo, I think so. Virgo said B, C, E. Yeah. So Virgo had said B, C, E. So remember, this is the one that we are working with, okay? So this is acidic. This is the respiratory system. And we know that the normal value is going to be what, 35 to 45. And then we have the bicarb here. So we have a mix. So we have a respiratory acidosis with, the kidneys compensating. So it is definitely not metabolic acidosis only. It's a combination of metabolic acidosis and respiratory acidosis. Oh, you missed the HCO3. Okay. Then we say that it's worsening CO2 retention. Okay. And we say impending respiratory failure. But it's not improved oxygenation. So the PaCO2 is increased, that's respiratory failure. Bicarb is still low. PaO2 is barely improved. So you have a combination of acidosis and poor ventilation, which is a high risk for intubation for this patient. Okay. Which order will you question? So the provider adds some, based on the results he got, he added some new orders. Which should the nurse question? A, start norepinephrine if the MAP stays less than 65. B, restrict fluids after initial bolus. C, sedate patient for possible intubation. Or D, administer 100% non-rebreather mask. So which order would you question? So these are the newest order that you received. A, start norepinephrine if the MAP stays less than 65. B, restrict fluids after initial bolus. C, sedate patient for possible intubation. Or D, administer 100% non-rebreather mask oxygen. So start norepinephrine. So is this appropriate for a MAP below 65? Treat each answer as a true or false, and if you're able to do that, then you'll narrow down your answer. So start norepinephrine if MAP stays less than 65. We know that we want the MAP to be greater than 65. So if you have this patient on fluids, the MAP is less than 65, we're going to want to give something else, which is usually the vasopressors. Norepinephrine is good to go. Restrict fluids after initial bolus. We ain't restricting no fluids here. Why? Because the patient is hypotensive. So we'll be addressing that. So we're not going to restrict. It's not a case where you give 1 liter and then you say no more fluid. No, they're dehydrated. They're not perfusing, so they need the fluids. Sedate patient for possible intubation. We know that patient, as a part of, the intubation process, there will be. But if a doctor comes and say, go ahead and sedate the patient for possibly intubation, everybody should be around. So I will probably put a question mark beside this one, okay? And administer 100% non-rebreather mask oxygen. So we know that, the patient respiratory system is not doing well. So, oh, there was another one. So we know that the respiratory system is not doing well. So if they say increase oxygen, then that's fine. That's fair enough. Or give IV morphine for dyspnea. Is that something that is okay? If you have a patient having shortness of breath, would you give them? Is this a select all and apply? Yes, so let's select all that apply in this one. I don't think I'd... Yeah, go ahead and select all that apply, because even if it is one that you're correct with, then, all right? So give IV morphine for severe dyspnea. We could always go ahead and tick that one. So which order will you question? B and D, restrict fluids after initial bolus and administer 100% oxygen. And then I see B and C, sedate for possibly intubation. And then I see E, IV. Okay, let's go down and see. Oh, so the one that we're going to be questioning, okay, is E. Morphine causes respiratory depression. It's lethal in ARDS physiology. Cause respiratory depression. Gmail, you know that one? Okay. Yes, plot twist. I totally forgot about the ARDS earlier. I know we were talking about it, but I wasn't really thinking along that line with the ARDS being present. So yeah. So let's go back to it again. So the provider adds new order. Which order should the nurse question? We said the norepinephrine is fine. Restricting fluids after fluid bolus. But so this one, the restrict fluids after fluid bolus, I'm trying to understand. Let's go down to the, didn't give much. I'm trying to understand why would we restrict fluids after initial bolus. Jamel, are you able to help us with this one? But why would you give a patient that is retaining acid and the fluids is trippy? Oh. So we have okay, so we still have the worst. Okay, remember that this patient, so to prevent pulmonary edema when you're okay, let me pull up. But why would you give? I read in your question, foreign, and the fluid is trippy. When you're hypertension, you don't give more fluids, you want them to come out. Virgo Princess, prevent pulmonary. Let's ask chat according to Google. Hold on. All right, let me go on to prevent fluid overload. Okay. Okay. It's like I'm reading the question and totally forgetting about the arts part. Hypertension is the body trying to compensate for that, eventually correct itself, yeah, because of the fact that the kidneys are currently compensated and may lead to fluid retention. Okay, MJ trend to prevent the fluid overload. Okay, I wasn't really remembering the arts part of the question or the diagnosis. Okay, so we know definitely with the ARDS, you want to restrict the fluids after the initial bolus. I was just thinking along the line of a regular just sepsis and there was no ARDS. So, okay. So, thanks for that. So, we'll start the norepinephrine. That will be fine. Restricting fluids after the bolus because of the risk for overload in the ARDS patient. Sedate patient for possible intubation. Like as I say, I know we would sedate them, or if it is a rapid, then we'll give them something. But this one, depending on how you interpret it, because if they're gonna say give the patient some medication in preparation for, and the intubation is not gonna be no, then I would question that one. So it depends on the time period that they're talking. But if it's a part of the rapid sequence intubation, then sedating is fine. Okay, so that one, as I say, it would have been like a question mark just because I want to be sure of when the intubation will be done. Because you don't want to go ahead and give the patient the medications and then 15-20 minutes later is when you're thinking about intubating. That don't make no sense. So I've been 100% non-rebreather mask oxygen. As I say, for that one, the patient is retaining. Go get a bath for me. They're hypertensive, tachycardic. Yes, they're hypertensive and tachycardic. So this was a tricky one with the ARDS added to it. And then give IV morphine for severe dyspnea. Okay. So morphine causes respiratory depression, lethal in ARDS physiology. So I guess we need to read up a little bit more on ARDS to understand more about the pathophysiology, and then from there. But this was a good one. Okay. During reassessment, which finding is most concerning for imminent ARDS deterioration? So during the reassessment, which finding is most concerning for imminent ARDS deterioration? A, respiratory rate increases to 40 breaths per minute. B, SpO2 94 on high flow nasal cannula. C, patient is more alert. D, the lung sounds show mild wheezing now. And E, the temperature drops to 101 degrees. So during reassessment, which finding is most concerning for imminent ARDS deterioration? A, yes. I see D, lung sounds show mild wheezing now. But mild, if patients have ARDS and they're having mild wheezing, is that probably something you would be expecting? Wheezing indicates a big problem, but the mild, yeah, the mild is not anything that would be much of a concern for me, because if the patient has mild wheezing and the respiratory rate is now at 40, then I would address I would be more concerned about that increased respiratory rate there. So let's see. So A, The respiratory rate is increased because they're exhausted. Patient is failing, likely needs intubation, mechanical ventilation ASAP. So I'll say yes, you don't want a patient to be wheezing, but you'll be thinking that it's expected for a patient that has ARDS to be having some form of wheezing there. But if their respiratory rate is increased, then they're working real hard, so they're deteriorating there. SpO2 of 94 is pretty good, so we're not concerned about that. The patient is more alert, so they're perfusing well. Temperature drops to 101 is improving because initially it was what, 103? So, you know, those are pretty normal. Could indicate fluid overload though. Yes, the mild wheezing, yes, could be indicative of that. But if you were supposed to, you know, look at A and D and choose to see which one of them is more concerning for ARDS deterioration with the respiratory rate, then I would go with the respiratory rate just because it's mild, you know, the mild wheezing. Yeah. Yes, Nori, thank you for joining in. Okay. So the patient's oxygen saturation drops to 80% on the high flow nasal cannula and she becomes obtunded. What should the nurse do next? A, increase the high flow nasal cannula oxygen flow. B, call rapid response and prepare for intubation. C, switch to BiPAP. D, give another fluid bolus. Or E, call provider and wait for orders. All B, nice. Code the patient. So you want to go ahead and call rapid response and prepare for intubation. Call provider and wait for orders. You know, eventually the provider will be aware, but you can't be waiting for orders. So we'll put an X beside that one. Giving another fluid bolus. We know that this patient is already wheezing. All right, the patient is already wheezing. It's an ARDS patient, so we're not going to give any more fluids. Switch to BiPAP. Will that help? Remember that this patient is now at 80%. Or are we going to increase the high flow nasal cannula? I will go ahead and do B because it is, so you have the high flow nasal cannula failure, ARDS. So BiPAP is contraindicated because of the risk for aspiration and delayed intubation. So immediate airway control is required. So we'll go ahead with coding this patient and prepare for intubation. Okay. Okay, and then I think I'm gonna do 10 more questions and then, oh, it's 8:20. And then we will, wants to meet Jesus, I guess. Yeah, we'll try to not, you know, send them there. Okay, a child with Kawasaki disease has persistent fever. What is the priority treatment for this patient? Jordan, wagwan. What time? Oh, the time now for me is 8:20. It is Central Standard Time. So, child with Kawasaki disease has persistent fever. What is the priority treatment here? Aspirin for Kawasaki. That's the only time we give children aspirin, right? Don't give a child aspirin at any other time. Acetaminophen, Jean and Jamel. So, the priority here for this patient is IVGI, IV immunoglobulin, reduce inflammation and prevents coronary artery aneurysm. So, this patient is definitely going to need to get follow-up with a cardiologist after this diagnosis of Kawasaki. Okay, so they need to get the immunoglobulin, but aspirin, they'll be given aspirin as a part of their treatment. What are some classic signs of Kawasaki disease? What do we know about Kawasaki disease? Just drop it in the chat. Isn't there a cherry tongue? Yes, it's more of a strawberry tongue. Strawberry tongue or pink skin on, yeah. It's a strawberry. It looks like a strawberry. Strawberry tongue Siggy, yes. And they tend to have the fever. Is strep, are these patients, is strep Does this condition have anything to do with strep? Like a strep throat? So acute systemic inflammation? No. Fever, swelling in the hands and in the feet? Yeah, all right, so let me pull this up. So it's acute systemic vasculitis, mostly in children less than 5 years old. Causes unknown, but it's immune mediated, possibly triggered by the infection like strep. So sometimes, the parents will say, oh, they weren't feeling well about a week ago. They had a strep throat, but no, the patient presents to the emergency room with a strawberry tongue. So a lot of times they might present and you hear the history of they're having like a strep throat, but their swab comes back negative for the strep. But when you look at their tongue, it has that strawberry appearance. And that's how most of the time, with the Kawasaki, they go about with diagnosing. So they will tend to have the fever, greater than 5 days, bilateral conjunctivitis, but no pus. Mucous membrane changes, red lips, strawberry tongue, rash, polymorphous, often on the trunk. Extremity changes, red swollen hands and feet, peeling skin, cervical lymphadenopathy. So the complications for this is the coronary artery aneurysms that can lead to myocardial infarction in children. So one thing that is most important is to ensure that you educate the parents about the importance of the cardiology follow-up. So they're going to have to get cardiology consultation. Then the treatment is the IVG, which is the immunoglobulin. It is going to use reduce coronary artery complications, aspirin, anti-inflammatory and antiplatelet, and you want to monitor cardiac function. So every now and again, they might get their echocardiogram when they're going to see their cardiologist. So fever, so the nursing NCLEX tip they're saying here is fever unresponsive to antibiotics is a clue, and early recognition prevents heart complications. And you want to ensure that you're hydrating, doing your cardiac monitoring and fever management for these patients. So the most important thing for them is know that they need the IVG, know about the strawberry tongue. The parents will say that they've been sick with the strep throat for a few days, and you want to ensure that they keep their cardiology appointment when they're discharged. And after that, the disease, it seemed to go away. Okay. So reduces inflammation, prevents coronary artery aneurysms. Can cause vasculitis, yes. Nadia, yes. IVG. A toddler with iron deficiency anemia should increase which food? Which food do you need to increase with your patient with iron deficiency anemia? See, folic rich. Iron, so anything like a spinach, yes, you want to encourage them. Your red meat. My son had Kawasaki. Oh, I'm sorry to hear, Nadia. Was there any after effects? If you don't mind sharing, that is. Spinach, organ meat, yes. Liver, all of those red meat you want to encourage in their diet to increase on their hemoglobin. Okay, B12 and iron. A child with cystic fibrosis has thick mucus. What therapy helps clear the airway? What do we know about cystic fibrosis and thick mucus? So I have a child with, they got it on day 6, got IVG in time, everything good with cardio. Okay, nice, yeah. Because once you get it in time, a lot of times the patients, totally get resolved in terms of their symptoms. Chest physiotherapy, yes. Because of that thick mucus that they are building up because of the cystic fibrosis, they are gonna need their chest physiotherapy. Percussions, yes. Nebulizer, yes. You want to encourage like fluids to help with loosening up that secretions. So the most important thing here is the chest physiotherapy to help with mobilizing the secretions. So that is what is going to clear the airway. A child with leukemia has low neutrophils. What is the nursing priority? So you have a patient that has leukemia. They have low neutrophils. What is your nursing priority with this patient? Isolation, nice. Jordan. Stay home, no flowers. Reverse isolation, protective reverse, neutropenic precautions, hygiene, PPEs, yes. So this patient has leukemia, low neutrophils. You want to prevent infection with everything that you said there. Limit the amount of visitors. Preventing infection. Neutropenia increases infection risk, so you want to keep them on isolation. No fresh flowers. Yes, Siggy. So all of that is priority. A baby with GERD should have what positioning after feeding? No raw food, exactly. So a baby with GERD should have what positioning after feeding? Fowler's position upright, yes, because we know that with GERD, what happens in GERD? What's GERD? What GERD stands for? Gastroesophageal reflux disease, nice. So as the name suggests, reflux disease, if you have this patient lying in a supine position, then you're going to have the backflow, and that is not good. Going to be at risk for aspiration. Why not? Go and get a bath for me, please. Since when you don't know how to bathe? Go learn. So good. So upright position reduces reflux and aspiration risk for your patients with GERD, okay? A child with dehydration has a capillary refill of 4 seconds. What level is this? So you have a child with dehydration that has a capillary refill of 4 seconds. What level of dehydration? Mild, moderate, or severe? What is... And if you know the capillary refill time, the normal, then you'll be able to tell what level are they. Moderate to severe, okay. Anything that is between 2 to 3, less than 2 seconds is normal. So this is 4 seconds, it's more moderate to severe thereabout, okay. A child with asthma is wheezing. What medication should be given first? A child with asthma is wheezing. What medication should be given first? Albuterol. Why do we say albuterol? Short-acting bronchodilator. Why you want to give the albuterol? Albuterol is short-acting, yeah. But I want to hear the pathophysiology as to, the relationship between the albuterol and how it's going to work with this wheezing here. Okay, so decreases so no. The albuterol is not going to decrease the inflammation. The steroid is, the corticosteroid is going to do that. Dilate, bronchodilation, yes. Pharyn quickly opens the bronchioles, yes. Open the airway. So think about what's happening in asthma and wheezing. So the first medication is going to be your albuterol or your bronchodilators to help with opening that airway to allow for adequate, flow of oxygen. Then the corticosteroid is the one that is going to help with inflammation, drying up some of that secretion that is there. So you want to do that first before you give your bronchodilator. Not your bronchodilator, your corticosteroid. So your short-acting bronchodilator, albuterol, opens the airway quickly. So that is very important. A child with nephrotic syndrome has swelling. What causes the edema? What is nephrotic syndrome, by the way? What is nephrotic syndrome? What is nephrotic syndrome? Loss of albumin, yes. Kidney function, fluid retention. Yes, so when the kidneys are, you know, they're having massive like protein loss in the urine. Okay, what is the color for your patients with nephrotic syndrome? What is the color of their urine? So we say that they have the fluid retention, they're having kidneys with problems with their kidneys. What is the expectant urine color for these patients? Are their urine real dark? So if their urine is dark, what is the urine for the persons who have glomerulonephritis? Choice is orange. So frothy, dark, or brownish. So for cities, so the frothy or foamy is gonna be for your nephrotic. Okay, your nephrotic syndrome tend to have the foamy urine. And then your glomerulonephritis have the Pepsi color, dark looking, brown looking urine. Albumin makes it frothy. So the protein loss, yes, the protein in the urine tends to cause that. Water, pink is crazy. So the proteinuria, the excessive amount of proteinuria or protein in their urine causes it to have that frothy look or the foamy look. And then you have glomerulonephritis that has the dark color urine. They don't have much protein in their urine. So glomerulonephritis doesn't have much protein in their urine. So because you have the hematuria in glomerulonephritis, you have that color, the dark color. Okay. So a client with nephrotic syndrome has swelling. What causes the edema? We said that loss of protein in the urine. So they have low albumin, fluid shift into the tissue causes the swelling. Okay. A newborn with jaundice needs what priority intervention? So a newborn with jaundice needs what priority intervention? Phototherapy, light therapy, photo, nice. And we will give them the light therapy. What is happening? Exposure to sunlight, yes, Nadi. So what are we doing with the phototherapy? What is that gonna do for the patients? Yeah, keep the eyes covered. Decrease bilirubin. Yeah, it's gonna decrease the bilirubin levels. And have them excrete it in their urine and in their stool. Yes, breastfeeding is very important. So encourage your mothers to breastfeed because that is also going to help with getting rid of the bilirubin. Okay, so it converts unconjugated bilirubin into water-soluble form. So bilirubin can be excreted in the urine and the stool, and it prevents kernicterus, bilirubin-induced brain damage. So decrease the level of bilirubin, lower the jaundice. Yes. So all of that is correct. You don't want them under the, the light to be frying up. You don't want them to be too oily, too greasy. And then you put them underneath the, no, that's a problem, okay? So make sure you cover them, their eyes properly, and you encourage breastfeeding as much as possible. They do the phototherapy, and sunlight helps as well. So the newborn with jaundice needs what intervention, phototherapy, to help with breakdown of their bilirubin levels. A child with measles need what type of precaution? What precautions do we use for your measles? Jamaica, Wesley Kelly. I don't know if that's what you're asking. So a child with measles need what type of precautions? We say airborne. Yes, Arthur. Oops, it's me. You need airborne because of the spread through the air. So you get them on airborne precautions. And oh yeah, so ATV, measles, TB, and varicella. MTV. Okay. Alrighty. So that's 1 hour of class. Yeah. Alrighty. So we did those, and then we're gonna be Spider-Man droplets. So that wasn't bad. That wasn't bad today. Okie dokie. So you're welcome, you're welcome, you're welcome. We will read a little bit more on our ARDS and our ABG. Oh, where that gone, dear father? I think I lost my TikTokers. I lost you guys for a minute. You said 7 yesterday. I'm in the Philippines. Thank you so much. You're welcome. What did I say yesterday again? 7 p.m.? Yeah, I said 7 p.m. yesterday. So it is what time now for me? I started at 7. I started at 6:50, but I never started the question because I was waiting on the folks that's, we're running behind the clock. So I started at 6:45 thereabouts. Okay, no problem, Bubbles. Thank you so much. Remember to go ahead and subscribe to the page on YouTube so you can get the full length of the live streams, just in case you miss it, along with all the others that we have over there. And remember to go ahead and follow me on TikTok here as well. Thank you. Okay, Choi. Thank you. Thank you. Yes, I will be showing up for the 7 o'clock. I was late. You're going live tomorrow. Tomorrow, Wednesday. It depends on if I finish working time. If I finish working time, then I will try to jump on and we probably can go through 1 or 2 of the case study question. I'm taking the NCLEX on December 29. Okay. Well, hang out with us. And hopefully that will help with, just prepping you a little bit more. Yes, look out for the live stream tomorrow. I will try my best. I know I have about 9 patients I'm going to see. No, 8 because 1 passed. I think I have about 8, but they're going to be in the same group home. So it's not going to be that bad. But it was nice hanging out with you guys. As usual, I learn a lot. So that's it. That's the most important thing. And feel free to inbox me if you have any question. All right. Thank you for the heart me. Go ahead and inbox me if you have any questions. And then from there, if you have a topic that you want us to go through as well, inbox me and I'll try to add them into the live stream. Okay. Kenneth, how are you doing? All right, so I am gonna go now. I'm gonna try to finish some things and then iron. I'm gonna iron it. Yeah, I'm gonna try to see if I can iron, and then from there. So enjoy your day now, guys. They be mad about be. Spell that word. What word? ThinkNursing, one word. THINK nursing. NURSING. So on YouTube and TikTok, it's the same name. The handle is the same. Atlas, welcome. Watermelon. Okay. Call in. Immediately following a call. Okay. All right, then, guys, enjoy your evening now. All right, I'll see you guys tomorrow or on Thursday at 7 p.m. Central Standard Time. All right, bye. All right, enjoy your evening, guys, and thank you so much for tuning in. All right, I know you guys never really answer much, but it's nice having you over here as well. All right.